ด้วยวันนี้ผมอยากให้ดูเป็นมีประวัติศาสตร์ดีมากเพราะปีแรกที่ผมมาทำ ECFMG workshop นะฮะตัวผมยืนอยู่นี่หมอศิลป์อนุราชจำได้ไหมฮะหมอศิลป์อนุราชอาจารย์ประดิษฐ์เจริญไทยชวีประสงค์ตุจินดาอัฐสิทธิ์พ่อคุณหมออภิสิทธิ์ใช่ไหมอาจารย์อาวุธแล้วก็ดีนทั้งหลาย by coincidence is our speaker father-in-law and he also come สมัยนั้นเรามาเจอระหว่างสมาคมแพทย์ไทยในสหรัฐกับคอนโซเทียมของ Thai Medical School การวางแผนการช่วยเหลือ resident ไทยไปศึกษาต่อต่างประเทศและเป็นครั้งแรกที่ผมมาทำ ECFMG workshop ที่ศรีราชสมัยนั้นก็ไม่ไฮเทคแต่ก็เนี่ยรุ่นเนี่ย by product so that your next speaker isใช่เลยครับ
There we go. All right. I'd like to introduce our last speaker of the day, last but first in our hearts, Dr. Rosanee Valyasevi, who went to medical school in Bangkok but came up here to do internal medicine in Chiang Mai. She has since done several endocrine clinical and research fellowships in the United States after doing internal medicine in Austin. She's boarded here and in the United States in internal medicine as well as her subspecialty. And she's going to be talking to you about endocrinology.
Okay. Good afternoon, everybody. And first, I'd like to thank you, the organizing committee, for inviting me, and I'm really honored to be here today. I just think it's very hard for you to have been through 6 hours of intense review the whole day, and now have to spend 2 more hours with me. So just keep going, okay? The first case will be a 50-year-old woman present with dizziness, and she also has flushing, abdominal cramping, severe watery diarrhea for the past year. She also has the skin lesion, dry, itchy skin, has some systolic murmur. She doesn't have any wheezing, bronchi, or crackles. Her lab results are unremarkable. Which of the following is the most appropriate next step in diagnosis? A is barium enema. B is to check serum lipase and amylase. C is to do the abdominal ultrasound. D is to collect the urine for 5-hydroxyindoleacetic acid. And E is to do small bowel biopsy. It's probably easy for you to know that we are doing endocrinology, so it's probably part of the endocrine. Would you like to vote, please? Okay, I think 73% of you got it. This is the classic triad of carcinoid syndrome, flushing, watery diarrhea, and valvular heart disease, and mostly on the right side heart disease, becoming more common than the left side. Some patients may have hypotension, bronchospasm, abdominal cramping. The skin disease that was described in this case is probably dermatitis that we found in pellagra, because in this group of carcinoid, they use the substrate is tryptophan to make the serotonin. And so the tryptophan is also the precursor for niacin. So they ended up having secondary niacin deficiency. And the screening test, it's 24-hour urine, 5-HIAA, Once we get the biochemical diagnosis, we do localization by abdominal CT scan and sometimes octreotide scan, and the treatment is surgery or octreotide. The next case is 26-year-old woman with 10-year history of type 1 diabetes. She has maintained strict glycemic control and no complications so far. Her blood pressure was good, less than 130 over 80. Her blood chemistry were all in normal limits. The fundoscopic exam showed no evidence of retinopathy. Which of the following is the most appropriate next step in management to prevent diabetic nephropathy? A. Periodic measurement of creatinine levels. B. Screening for microalbuminuria with the dipstick. C. Screening for microalbuminuria with 24-hour urine. D. Start on ACE inhibitor. Or E. Do the renal biopsy. You can vote now, please. Okay. Actually, the answer is C, screening with 24-hour urine collection. I would say this question is not quite a perfect question. Number one, we know that the creatinine is late in the stage of diabetic nephropathy. Choice B, for the dipstick urine, to be able to detect, it has to be overt proteinuria to be able to use the dipstick. C, 24-hour urine is the one that we can detect early on microalbuminuria. But actually, if you look at here, what we usually do the most is actually spot urine microalbumin to creatinine ratio, which is not in the choice, but if it happened this year, you can choose this. It's the preferred screening test, and it's correlated with 24-hour urine collection. Microalbuminuria is considered when there's a measurement of 30 to 300 milligram per gram of creatinine, and macroalbuminuria is more than 300. Next case is 30-year-old man present with rapidly enlarging single stony heart, palpable 2.5 centimeter nodule in his thyroid gland. The thyroid scan demonstrates cold nodule. On resection and subsequent pathologic examination, this nodule contains follicular structures, some of which have inwardly protruding fibrovascular branching core covered by epitheliums, and also this is like the clue. And I just talked to Dr. Graham, and she mentioned it on the previous day about orphan Annie nuclei. So this is the pathognomonic of what type of thyroid disease. Go ahead, please. Okay. Okay. All right. Equal between follicular and papillary. You just need to remember orphan Annie is pathognomonic for papillary thyroid cancer, PTC, also like the Samoma's body. Follicular thyroid cancer will be difficult to diagnose on the FNA. Usually it's going to be read as follicular neoplasm, and we ended up have to remove on like the lobe, if it's like on, in this case, one side of the thyroid, and go through the section. If it shows capsular or vascular invasion, we rate it as follicular thyroid cancer. So in general, this is the classic pathology of papillary thyroid cancer. This probably cannot see well, but if you will see it, the nuclear, there has like a cleft, groove, ground-glass cytoplasm, and the nucleus itself has a hole. This is a little bit dark, but this is what it called orphan Annie's eyes. 22-year-old woman come for the first physical examination in several years. She's always been in good health except for irregular menses. She doesn't take any medication. Her blood pressure was 137/80. She's only 160 centimeters tall, but her weight was 83 kilograms. She has slight increase in upper lip and chin hair. She reported that she has been gaining weight since the age of 15. Which of the following is the most appropriate next step in management? A, no intervention. B, explain the risk of obesity and benefit of weight loss. C, do some lab investigation to exclude secondary causes of obesity. D, referral to weight reduction program for very low calorie diet. Or E, start patient with sibutramine. You can vote now. Okay, I think you got it most of it. This case, if we calculate the BMI is about 33. Definition of obesity is the body mass index that we use weight in kg divided by height, square height in meter. So 30 or greater is considered obesity. This is, you probably have to remember this one because you're going to take the test for Caucasian, for American. Though in Asian population, we use different criteria. Now, besides that, recently we have been paying more attention on waist circumference as part of metabolic syndrome. And if it's more than 88 centimeter, which is about 35 inches for female and 40 inches for male. And increased abdominal obesity also is correlated with diabetes, hypertension, dyslipidemia, and cardiovascular disease. Whenever we see the patient, we have to think of secondary causes. Can she have hypothyroid? Can it be Cushing syndrome or some genetic cause? In this patient, because she has also menstrual irregularity and some mild hirsutism, so the most likely diagnosis will be the polycystic ovarian syndrome. Some medication also can make patients gain weight, like antipsychotic medication, antidepressant, steroids. A 30-year-old man present to emergency room with severe headache, visual change, palpitation. Look at his blood pressure, 190/130. His pulse rate is 130. The remainder of the exam was unremarkable except for clamminess of the hand and increased sweating on the face. The hypertension was treated. 24-hour urine specimen demonstrate elevated methanephrine, VMA, and homovaleric acid. The patient told us that he also have the endocrine problem in the family. So this patient is most likely at significantly increased risk of developing which of the following thyroid diseases? Graves' disease, Hashimoto, medullary carcinoma, multinodular goiter, or papillary carcinoma. So you can start vote now. Okay, good. So this is the picture of pheochromocytoma with sometimes when I was medical student, I was taught that 5 P's for pressure, for palpitation, pain, which means like headache, perspiration or sweating, and pallor. We do the 24-hour urine for fractionated methanephrin, catecholamines, VMA. And when you see pheochromocytoma, you have to think of the familial forms, which will include MEN2A and 2B. And both MEN2A and 2B have medullary thyroid carcinoma. In MEN2A will have a picture of hyperparathyroid, but in 2B you will see mucosal neuroma and marfanoid habitus. Next case is otherwise healthy 60-year-old man came for checkup and was found to have serum calcium of 11. Repeated, still get 10.5 and 11.2. Serum phosphorus is 2.5 and alkaline phosphatase is 50. The ERMA assay show higher than normal of parathyroid hormone. The urine calcium excretion is within normal limits. The patient denied previous renal colic or urinary tract infections. Which of the following is the most appropriate next step in management? Bone X-ray film, extensive cancer screening, generous fluid intake, or start treatment with bisphosphonates, or do the surgical exploration of the neck. Please vote now. Okay. Actually, the answer is C, generous fluid intake. So this is the case of primary hyperparathyroidism. First, when we see patient with hypercalcemia, we look at the PTH to see if it's PTH dependent or PTH independent. In this case, the PTH was higher than normal, so it will fall into this category. Either the most common will be primary hyperparathyroidism. May see tertiary hyperparathyroid in chronic renal failure. This will be in young patient and running in the family. It's called familial hypocalciuric hypercalcemia. In this syndrome, there's a mutation at the calcium sensing receptors. So the parathyroid see high calcium as a normal calcium, still making continue to secrete parathyroid hormone. So the calcium was high, but the PTH was not suppressed. For patient who's on lithium may have high calcium too, because the lithium reset the parathyroid, the same like set point for the calcium level. So it needs higher calcium to suppress parathyroid hormones. In the second group, or this group, most common is cancer. The PTH should be suppressed. Hypervitaminosis D, hyperthyroid, adrenal insufficiency, some medication like thiazide, vitamin A or milk alkaline syndrome. Now, primary hyperparathyroidism, what we need to know is the indication for surgery. If the serum calcium is more than 1 milligram above upper limit, and upper limit we usually is about 10.5, so if we see 11.5 or higher, we consider surgery. Or if they have high 24-hour urine calcium, because this will prone them to develop stone. If the creatinine clearance reduced by 30%, so or the patient has T-score on BMD below 2.5, or young patient, because they have to live longer to develop complication. This patient actually she was sick. This patient was 60-year-old man. The calcium is not more than 11.5. The urine calcium was normal, and the patient never have stone, and assume that probably have normal renal function. The only thing that is not included is the bone mineral density that they didn't do. But from this information, they probably want to point out that he's having like asymptomatic hypercalcemia. So in this case, we just encourage them to increase fluid intake to prevent kidney stones. 72-year-old man complained of malaise and easy fatigability for 3 weeks. He lives alone and he's a drinker. He was found to have diffuse ecchymotic rash spreading out from hair follicles over the limbs and trunk. The patient most likely has a deficiency of which vitamins? Niacin, thiamine, B12, vitamin C, or vitamin D. That will give this skin ecchymotic rash from spreading out from hair follicles. Please vote. Okay. So So this is vitamin C deficiency. I think this vitamin C deficiency, I think they like this question in board exam too, because when I was in the state, they always have this question: perifollicular hemorrhage, purpura, splinter hemorrhage, gum bleeding, normochromic, normocytic anemia. Now, if it's niacin deficiency, it will be the pellagra, 3Ds, dermatitis, diarrhea, dementia. For thiamine B1 deficiency, they will have like cardiac beriberi. They might have like Wernicke-Korsakoff. For B12 deficiency will be megaloblastic anemia. And vitamin D will be rickets or osteomalacia. Next question, 37-year-old man is having insomnia, irritability, palpitation for 3 months, and he's on amiodarone for cardiac arrhythmia. His blood pressure was 130/70. His pulse rate was regular. Which of the following is the most appropriate next step? To check for thyroid function, to give propranolol, refer for psychiatric consultation, or we change antidepressant, or we should change the antihypertensive medication. You can start voting. Okay, great. So this is a case of amiodarone-induced hypothyroidism. Amiodarone is a class 3 antiarrhythmic that can cause both hypo and hyperthyroidism because it has high iodine content. In one tablet of amiodarone that is 200 milligram will have 6 milligram of iodine. And in the US, the daily iodine intake is only 0.3 milligram. So it's about like 20-fold higher than the daily intake just by one tablet. It has also a direct toxic effect on the thyroid cells, can cause destructive thyroiditis. So the recommendation is to check thyroid function test before starting amiodarone, and then every 3 to 4 months until 1 year after stopping. So after we stop amiodarone, we need to continue checking it for another year. A healthy 40-year-old woman she discovered a painless nodule in her neck. It's a firm 1 centimeter nodule in the left cervical region and move upwards as the patient swallows. So this tells us that this is a thyroid nodule. The FNA is positive for papillary cancer. Which of the following is a recognized risk factor? Amiodarone treatment, dietary iodine, MEN, Graves' disease, Hashimoto, radiation to the neck, subacute thyroiditis, or thyroglossal duct abnormalities. You can vote now, please. Okay, maybe because it has several choices. Okay, then you probably know that it's the radiation to the neck is definitely a risk factor, and it increases both benign and malignant thyroid tumors. For malignant thyroid tumors, also it's a risk factor for both papillary and follicular thyroid cancer. A 35-year-old man is brought because he faints. His sugar was found to be only 23. He was given IV glucose and recovered his consciousness. He has a family history of endocrine abnormalities. The blood workup showed the insulin level was high at 120, and the CT scan of the abdomen demonstrated a 2 centimeter mass in the tail of pancreas. Which additional finding will most likely be seen in this patient? Marfanoid habitus, medullary thyroid carcinoma, mucosal neuromas, parathyroid adenoma, or pheochromocytoma. Start voting. Okay. I think we have talked about the pheochromocytoma is part of the MEN2. If you remember the earlier slide that we talked about MEN2A and 2B, it has medullary thyroid cancer with pheochromocytoma and with primary hyperparathyroid in 2A, and 2B will be having, if you see the choice, mucosal neuroma and marfanoid habitus are found in the same group, MEN2B. And with the medullary thyroid carcinoma and pheo, so this is part of MEN2. But when we see insulinoma, it's pancreatic tumor. This is group of the MEN1. 3 Ps, pituitary, parathyroid, and pancreas. So MEN1, remember 3 Ps. Wermer syndrome, the most common manifestation will be hyperparathyroidism, and second will be the pancreatic tumor. More common is gastrinoma, which can present as Zollinger-Ellison syndrome with several peptic ulcers disease, or insulinoma that can cause hypoglycemia. About 10 to 20% of patients can have pituitary adenomas. Still, the most common is prolactinoma, followed by acromegaly and Cushing. So this patient has insulinoma. We have to look for the parathyroid. 45-year-old woman come because of the blurred vision. She also has candida vaginitis. She's obese, weight 84 kg. She started to have dot retinal hemorrhage. Her family history is positive for obesity, coronary artery disease, type 2 diabetes. The dipstick urine is normal. Which of the following is the most appropriate next step in diagnosis? A. Blood test for C-peptide. B. Fasting blood glucose. C. Glucose tolerance test. D. Glycosylated hemoglobin. Or E. Urine glucose. And F. Urine protein. Please vote now. Yes. So this patient will be diagnosed. The question will be how to diagnose diabetes. We still use fasting plasma glucose at or greater than 126. Or in some patients, if we do the glucose tolerance test at 2 hours, it's at 200 or higher. Or if the patient has random glucose of 200 or higher, but also needs to have symptoms, polyuria, polydipsia, we can diagnose on that too. All of this need to be confirmed on a subsequent day. A 31-year-old Asian American with 19-year history of type 1 diabetes. He's using 10 units of NPH every morning and 8 units of NPH in the evening. He also does the frequent blood glucose check and regular insulin dosing throughout the day, but he does not keep a log, the record of his glucose. The urine dipstick show 2+ albumin. Hemoglobin A1C is 7.9%. Which of the following is the most appropriate next step in management to prevent morbidity? A. Add a standard regular insulin dose at lunchtime. B. Begin ACE inhibitor. C. Discuss option using insulin pump. D. Increase his morning NPH dose. Or E. Send 24-hour urine specimen for total protein. Please vote. Okay, so this patient, the answer is B. We know that he has His glucose probably is not well controlled because the A1C was 7.9%. And he doesn't keep the record of his glucose. So if you're going to change the insulin or do the insulin pump or NPH, we don't know how to adjust on that. This patient already has proteinuria, so we have to start ACE inhibitor. Because ACE inhibitor has been shown to prevent and slow progression of diabetic nephropathy, so we can start, number one, if the patient is hypertensive, and number two, if the patient is having microalbuminuria, even the blood pressure is normal. So either way, we can start ACE inhibitor. A 55-year-old patient present with chronic cough. Also, the patient has been gaining weight and developed buffalo hump and Cushingoid features. Chest X-ray demonstrate a mass in the central area of the chest. Bronchoscopy is performed, and it proved possible to biopsy the tumor during the procedure, which means that the tumor is central part of the chest. Which of the following is the most likely diagnosis? Adenocarcinoma, bronchoalveolar carcinoma, large cell carcinoma, small cell carcinoma, or squamous cell carcinoma. This patient is having Cushingoid feature. Yes. So paraneoplastic syndrome from lung cancer. What you need to remember is that so many of them are due to small cell cancer. Cushing due to ectopic ACTH production or SIADH. But the only difference is calcium. The high calcium will be found in squamous cell carcinoma. In some of the large cell cancer, making HCG can cause gynecomastia and galactorrhea. A 35-year-old man come with palpitation. He has several episodes in the past few months. What you find, the blood pressure was 170 over 135. His pulse rate was 140. He has diaphoresis. And within the hour before the definitive treatment is begun, the blood pressure dropped spontaneously. So it's like paroxysm. It went up high and it came down. His symptom improved. Which of the following measurement in 24-hour urine can confirm the probable diagnosis? 17-hydroxycorticosteroid, porphobilinogen, pregnanidyl, tetrahydrocortisol, or VMA. Start voting. Okay, I think we have been through. So when we suspect pheochromocytoma, we can do either, actually if we choose only the best answer will be 24-hour urine fractionated metanephrine, but the choice that they give doesn't have, so you can choose the VMA. 40-year-old woman present with increased nervousness for 3 months, insomnia, palpitation. This one makes us think of hyperthyroidism, right? And then the blood pressure was 150 over 60. High systolic blood pressure. The heart rate was 135. She's anxious. And in the middle of winter, she's just wearing t-shirts and shorts. Physical exam revealed proptosis and eyelid retraction. Moist skin, mild hand tremor, and palpable diffuse goiter. This is also one clue. Which of the following is the most likely diagnosis? Uterine 6 syndrome, follicular thyroid cancer, Graves' disease, Hashimoto thyroiditis, or subacute thyroiditis? Start. Okay. So the answer is Graves' disease because the patient is hyperthyroidism with diffuse goiter. 29-year-old man developed chronic weakness and fatigue. He also feels dizzy when he stands up in the morning. He also has cold intolerance and frequent urination, so it seems like several things put together. He has facial puffiness, coarse and sparse hair, and hoarse voice. The lab shows low sodium, 125, high potassium, 5.5. Look at his sugar. This probably can explain polyuria. And the TSH was also elevated at 9.5. Which of the following, oops, how can it go? Which of the following is the most likely diagnosis? MEN1, MEN2A, 2B, or polyglandular autoimmune syndrome type 1 or type 2? Okay. Well, it's a little bit difficult, this case. Okay, at least you know that it's polyglandular. I'm not sure because you saw the answer first. But this picture is different from MEN. MEN is a tumor that's making too much hormone. So you see the sign of like endocrine tumor. But this one, number one, what do you suspect when the patient has weakness, fatigue, orthostatic hypotension, hyponatremia, hyperkalemia? You think of Addison disease. So it's the lack of the hormone. So it's different category between MEN, too much hormone, or the lack of the hormones. Also hypothyroid, the lack of thyroid hormone. And also the glucose, also part of the no insulin. So polyglandular deficiency syndrome, type 1 and type 2. Type 1 will have the first three common, they usually develop mucocutaneous candidiasis, usually in the mouth, sometimes in the nail bed, and hypoparathyroidism. The upper two will happen early in their life, maybe the age of 4, 5, or 6. And later, after the age of 10, they can develop adrenal insufficiency. About 50% of them have primary hypogonadism. On the other hand, candidiasis is not part of type 2. You still see adrenal insufficiency and autoimmune thyroiditis, mostly Hashimoto, but sometimes can be Graves' disease. And the first two categories used to be called Schmidt syndrome. And then they can have type 1 diabetes and primary hypogonadism. So this is type 2, polyglandular autoimmune syndrome. Next case, 1 week after delivery, 27-year-old woman complained of polyuria, polydipsia. His pregnancy, her pregnancy, cannot be his, her pregnancy was normal. She began to feel unusual craving for ice water in the last month of gestation. This is also for this group of patients that prefer ice water. And she's forced to get up at night several times to urinate, and she drinks large amounts of water. Her blood pressure is normal, electrolytes are within normal limit. 24-hour urine collection yield 10 liter volume in 1 day. Low specific gravity, no sugar, and low protein. Which of the following is the most appropriate next step in management? A. Advise the patient to reduce water intake. B. Perform vasopressin challenge test. C. Order MRI of pituitary hypothalamic region. D. Refer to psychiatrist for compulsive water drinking. Or E. Refer to nephrologist for evaluation of nephrogenic DI. This is a little bit difficult question. Okay, I think most of you got the answer. The answer is B. Actually, will be to do the, in this case, polyuria, polydipsia, and no sugar, low urine specific gravity. Let us think of diabetes insipidus. Now, the clue is the second half of pregnancy they can have is called gestational diabetes insipidus due to the release of vasopressinase from placenta. And so these enzymes rapidly degrade ADH. So the patient can present with polyuria, polydipsia, can have high serum sodium, and the test will be to do water deprivation test with vasopressin challenge test. If you look at, just to go quickly, the answer, they want to ask for type 1 diabetes, which HLA type is associated. Would you like to vote now? So this is truly random, randomized control. So actually it's the last one, DR3 and DR4. I know it. So type 1 diabetes in Caucasians is associated with HLA, DR3 and DR4. They have islet cell antibody, anti-GAT65 or insulin antibody. It's an immune mediated destruction of islet beta cells. So we find type 1 in younger patients, they are DKA prone and they require insulin. Okay. 24-year-old woman, she complained of not feeling well for the past several days. She denied fever, nausea, vomiting, or abdominal pain, and she has been drinking a lot of fluid and urinate every 1 to 2 hours during the day, but she get up once or twice at night to urinate. She has history of major depression. She's well hydrated. On the physical exam was normal, except for this systolic murmur. Which set of laboratory finding is most compatible with the diagnosis? So you have to think first, what does she have, and then you can think of the lab test. A, hypernatremia and high urine sodium, hyponatremia, high urine sodium, hypernatremia, low urine sodium, or both low or high sodium and normal urine sodium. I think I will not have you vote this case. So this is just a case of primary polydipsia. So they will have delusional hyponatremia. I think one thing that we can see, at night she get up only once or twice, like it is considered to be still be okay. If you remember the previous case of diabetes insipidus, they have to get up several times. In primary polydipsia, because they drink too much water, so the serum sodium will be low, and the urine sodium also will be low. So the answer would be D. In diabetes insipidus, usually the serum sodium is normal. They will have high serum sodium in diabetes insipidus only if, number one, the thirst center was not intact. So they don't feel thirst, so they will not go and find water to drink. Or number two, they don't have access to water. Otherwise, they will just live normal, like normal human being, just drink water and go to the bathroom and maintain that serum sodium. 45-year-old man, okay, this is, face and voice have changed. He met his nephew who he hasn't seen for 2 years and could hardly recognize him. He has joint pains, blood pressure 140/90, so it's higher than before. He has coarse facial feature, large tongue, thick fingers. His hand was moist and duffy, and his voice deep. So you think of, oh, what does he have? And now they don't ask the diagnosis, they ask which of the following is the most appropriate next step. CT scan, MRI. So if they have both together, it's probably not a good answer. Measurement of baseline growth hormone level, or measurement of growth hormone level following glucose suppression test, or to check the TSH. Please vote. Okay, most of you got it. It's to do the glucose suppression test. The baseline growth hormone level alone is not a good screening test because it's overlap between normal and patient with acromegaly. Acromegaly is caused by growth hormone production, overproduction by pituitary adenoma, and they have all these change. They can have secondary diabetes, hypertension, arthritis, and cardiomegaly. Actually, the first screening test will be to do IGF-1 level because that is a pretty good screening test. But the confirmation test will be the glucose suppression test. And if the test is positive, we do MRI of pituitary.
Okay, we'll take a stop there for just about 5 minutes before we finish up the last hour, okay? Thank you. Okay, well, everybody's warmed up. It's a little cool. That'll help keep you awake for the next hour. Okay. Oh, no, don't put your head down.
Right. Okay, next case, a 30-year-old woman. She presented with white discharge from her nipple for the past 3 months. So this is galactorrhea. She denied headache or visual problem. She often feels tired, but because she has to take care of 18-month-old daughter, she has not had menstrual period since her delivery and has not nursed her baby for the past 5 months. She's not taking any medication. So all they tell you to exclude the cause of hyperprolactinemia. Her physical exam is unremarkable. She does not have any visual field defect. The prolactin was 200. Which of the following is the most appropriate next step? Chest X-ray, CT brain, check thyroid hormone. No additional investigation is warranted, or pregnancy test. Please vote. Okay, I would like to give, according to my experience with several like board exam or in-service exam, every time they give pregnancy test, pay more attention about pregnancy test on the choice. Almost always, not almost, always exclude pregnancy in secondary amenorrhea. And high prolactin of 200 actually is very high and make you think of prolactinoma. But pregnancy also can bring up the prolactin up to 600 at term. So first do pregnancy test. If it's negative, you can do MRI is better than CT scan for the pituitary. Now, 30-year-old man is brought to ER because of acute chest pain, so he has MI at the age of 30. His family history also significant for early MI. He has nodular lesions on his eyelids and on the several tendons. Here, they already told us that this is xanthomas on biopsy examination. The cholesterol was 350. Triglycerides are normal. Abnormality in which of the following protein most likely account for this patient's condition? ApoC2, ApoE, 3-hydroxy, or this, I don't want to say the name, coenzyme A reductase, LDL receptor, or lipoprotein lipase. Just choose one. Always like DR3 and DR4 is all random. So this is the case of familial hypercholesterolemia, right? Pure high cholesterol and triglyceride is normal, so it's type 2A. This patient have MI at young age, family history of early MI, and they have like tendon xanthoma, xanthelasma on the eyelid. It's autosomal dominant, and the defect is at LDL receptor gene mutation. Now, for some of you who cannot remember the 5 type of hyperlipidemia, the first clue is that remember 1 plus 4 equal 5. So 1, 4, and 5 are triglyceride. 1 is chylomicron, 4 is VLDL, and so 5, and both chylomicron and VLDL, we will see high triglyceride in the blood chemistry. So 2, they have 2A, 2B, and 3. So 2A is the FH, the familial hypercholesterolemia, just only high cholesterol. 2B will still have high cholesterol, but triglyceride is increased, but to the lesser extent than, so the triglyceride is high, but still less than cholesterol. But 3, both are about the same level. So the one in the middle have both about the same level. Now they give you, so ApoC2 and lipoprotein lipase will account for triglyceride type 1, 4, and 5. Now the way I remember ApoE is for type 3 is that I think E, if you switch E to the other side, you get letter 3, number 3. So this is what I remember. So this is patient will have IDL, and both will be elevated, and they will have like a Palmar or xanthoma. 61-year-old with history of diabetes and 30-pack year of cigarette smoking. Again, high calcium, 11.5. Albumin of 3.4. So if we correct it, it's probably will be higher than 11.5. Which of the following is the most likely diagnosis? Excess vitamin D, occult malignancy, Paget disease, PTH oversecretion, sarcoidosis. So the most likely diagnosis. You can start voting now. All can be the cause of the hypercalcemia except Paget disease. It's usually calcium is normal unless the patient was immobilized, like they have to stay in bed for a prolonged period, they can have high calcium. Still, remember the most common cause of asymptomatic hypercalcemia is primary hyperparathyroidism. But the most common cause of hypercalcemia in hospital is malignancy. So this is healthy people come in for checkup. You think of primary hyperparathyroidism first. And in older women, 85% is due to 1 parathyroid adenoma, 15% is caused by hyperplasia, and 1% is parathyroid cancer. And in parathyroid cancer, usually the PTH is very high and they can have palpable nodule. "52-year-old, okay, this will be interesting case. Severe epigastric pain, endoscopy show thickened gastric mucosa and several peptic ulcers in stomach and duodenum. The basal acid secretion is 75% following the maximum stimulation dose of histamine. Serum gastrin is very high, 1200 picogram per ml. Endoscopic ultrasound demonstrate a pancreatic mass, which is later resected. Following resection, serum gastrin decreased to 50. So this is proof that patient has a gastrinoma, so the tumor of the pancreas that make too much gastrin. And it also caused severe peptic ulcer. So this is the pattern of Zollinger-Ellison syndrome. Remember, think of the last hour that I talked about. What is that? Someone show me like 3. Okay. In addition to of this tumor, this patient would mostly develop which of the following? A, marfanoid. Probably cannot develop marfanoid later. Medullary thyroid cancer, mucosal neuromas, pheochromocytomas, or pituitary adenomas. Just vote now. Great. I think you got it from. So this is MEN1, 3Ps, pituitary, parathyroid, and pancreas. So the same as I say, Zollinger-Ellison syndrome, peptic ulcer, high basal acid secretion, high gastrin. More than 50% are malignant and associated with MEN1. Next case, 70-year-old woman, metastatic lung cancer. She was confused and obtunded. No history of head trauma. She's receiving chemotherapy for her cancer. Her vital signs are stable. The JVP of 7. Her lungs are clear. No edema. And the sodium was 124. So this is to approach hyponatremia. And so the first thing to assess the volume of the patient, right? The patient has no edema, so it's not edematous stage. The patient's JVP vital sign is good, so it's not hypovolemic. So she falls into the category of euvolemic hyponatremia. What can be the cause of that? CT head indicate no brain metastasis. What is the most appropriate next step? A, give diuretics and water. B, give isotonic saline. C, give water. Or D, restrict salt intake. Or E, restrict water intake. Please vote. Good. Okay, so causes of euvolemic hyponatremia can be hypothyroid, glucocorticoid deficiency, or it's IADH. So it can be found in trauma, infection, medication, neoplasm, small cell. So treatment is water restriction. And if we try to restrict fluid and we still cannot bring up the sodium, the next step is to give demeclocycline. So the demeclocycline, you will see it later, is the medication that can cause nephrogenic DI, the diabetes insipidus. So it's too extreme thing, and we can use it to treat the other. "50-year-old man, after a car accident, the X-ray film show no fracture, but the film show abnormal feature of the femur and tibia. He has microfractures, increased bone density, cortical thickening, bowing, and overgrowth. The lab finding, he has normal calcium, normal phosphate, and elevated alkali phosphatase with increased urine excretion of pyridinoline cross-links. Which of the following is the most likely diagnosis? Bone metastasis from prostate cancer, fibrous dysplasia, hyperparathyroid, multiple myeloma, or Paget disease. Normal calcium, normal phosphate, and high alkali phosphatase. Okay. So the answer is Paget disease. For those who answer bone metastasis, usually if it seems to be like he has several bone abnormality, think it's more like advanced case of cancer. Usually met into just some certain area, not have the this extent of bone change. So, and high alkali phosphatase is the one that we find in Paget disease. This disease has accelerated rate of bone turnover, which means high bone turnover, can be asymptomatic. They can have pain, they can have bowing leg, frontal, the head become bigger, the frontal bossing, fracture. They can have bone tumor, osteosarcoma, and they can have like hearing loss as part of the neurological deficit. Usually have high alkali phosphatase and normal calcium. The radionuclide bone scan is the most sensitive test for Paget disease, and the treatment is with bisphosphonate and sometimes calcitonin. And this is the skull X-ray. It's called cotton wool lesion. They have like a frontal bossing. Next case is 22-year-old woman, type 1 diabetes. Now I think you probably will see this question because I've seen several of this disease. Type 1 came to emergency room, sugar 760, sodium 125, potassium was low, and bicarb was low. The chloride was 92, so anion gap will be, in this case, about 21. So high anion gap. So the patient has high gap metabolic acidosis, positive for ketone. Which of the following is the most appropriate initial step? Broad coverage antibiotics, IV glucose and insulin, IV hypertonic saline, IV potassium, or just normal saline? Start voting now. How would you treat DKA? Okay, good. So so we look at 3 things: underlying cause, like if they have infection, we can give antibiotics. But the first thing will be IV fluid, volume depletion. We have to correct that, and they also need insulin. And later, the potassium will get lower, so they will need potassium. 23-year-old nun has a 6-month history of amenorrhea and galactorrhea. She's concerned that people will think that she's pregnant. The physical exam confirmed that she has milk coming from both breasts. The pelvic exam is unremarkable, no uterine enlargement, no ovarian mass. Visual fields are normal. Pregnancy test is negative. So now they didn't tell you the lab result, but they tell you once the diagnosis is confirmed. So you have to think of what she have, and then which of the following is the most appropriate management. Bilateral mastectomy, that bromocriptine, streptozotocin, sotocin, systemic chemotherapy, or tamoxifen. Start voting, please. Great. Okay, so amenorrhea, galactorrhea, negative pregnancy test, prolactinoma. So the treatment, it will be bromocriptine or carbapenem. 53-year-old man, chronic alcoholism, feeling weak, fatigue, so the question is hypocalcemia and hypokalemia can be caused by depletion of any of these: iodine, never heard of, iron, magnesium, selenium, or zinc. Just choose one. Okay, magnesium. Remember, magnesium deficiency can cause both low calcium and low potassium. So iodine deficiency, they can have goiter. Iron deficiency, they have anemia. Selenium deficiency can cause cardiomyopathy. And zinc deficiency, they can have like some skin disease or some growth retardation. So hypomagnesemia, we find it mostly in chronic alcoholism, malnutrition, chronic diarrhea, also hungry bone syndrome. We found this syndrome in patients who have parathyroid tumor, and after remove the tumor, because the rest of the gland was still atrophy, and the bone will take up lots of calcium, so the patient can have low calcium after parathyroidectomy. Some medication that can cause low magnesium is amphotericin B. So patient who's on this, we should monitor that: cisplatinum, pentamidine, cyclosporin, gentamicin. The symptoms may include anorexia, nausea, vomiting, lethargy, weakness, and seizure and tetany. Now, when you just take a brief look, you can see hyponat and hyperkalemia. 27-year-old woman come because of weakness, weight loss, amenorrhea for 6 months. Blood pressure was a little bit on the low side. Hyperpigmentation, hyponatremia, hyperkalemia, and the calcium was 10, still normal. CBC show mild lymphocytosis with eosinophilia, so classic of Addison disease. low plasma level of cortisol and high ACTH. So which of the following is the most common cause of this disease in the US? Adrenal leukodystrophy, autoimmune destruction, bilateral adrenal hemorrhage, fungal infection, metastatic disease, or TB. Please vote now. Okay, good. So Addison disease, the most common cause is autoimmune adrenalitis. I think I will just pass this that we talked about already. 29-year-old healthy woman come and was found to have half a centimeter nodule in the right thyroid. Physical exam otherwise unremarkable. She doesn't have any hyperthyroid symptoms. The TSH is normal. Which of the following is the most appropriate next step? So thyroid nodule, normal thyroid function test, MRI, CT, thyroid scan, FNA, or surgery. Vote now, please. Okay, great. So thyroid nodule workup, we do the TSH. If the TSH is normal, we do FNA, aspiration. But if the TSH is suppressed, which means that the nodule is functioning, we will do thyroid scan instead. And it's not included in the choice, but currently, when we find thyroid nodule, they recommend ultrasound because they can have more than one nodule that we cannot feel. And or we want to look at the characteristic of the nodule that may be suggestive of some malignancy. This patient, 75-year-old, brought to ER. She was found unconscious, had type 2 diabetes, glucose of 975. So the patient is type 2, probably not having DKA, but she's having hyperglycemia, hyperosmolar state, right? Which of the following would be? So BUN of 5, positive for ketone, no, creatinine of 0.3, osmolarity of 380, or serum sodium 132. So we don't have to, they already start voting, okay. Okay, so hyperosmolar, the effective serum osmo more than 320 and just no or mild ketone. We usually see high BUN creatinine because of dehydration, no ketone. Serum sodium is usually normal or high because they have lots of diuresis. Okay. 36 hours after surgical removal of large parathyroid adenoma, I think I just mentioned this a few minutes ago, parathyroid tumor, after surgery, this patient become irritable and tingling around the mouth, his hand, the facial spasm, Chopstick sign was positive. Serum calcium was 7.1. But when you see this, look at the clue, phosphorus, 7.5, it's high. So this phosphorus will tell us what the cause of it. Which of the following is the most likely cause? Atrophy of remaining parathyroid, which means like hypoparathyroidism, hungry bone, hyperventilation, magnesium, or metastatic parathyroid cancer. I will just go quick now. Post-parathyroidectomy, hypocalcemia can be from hypoparathyroidism or hungry bone. The clue is that hypoparathyroid, they will have high phosphate, as in this case. But in hungry bone, the calcium, the phosphate also will be sucked up into the bone, so they will have low. And if you will check parathyroid hormone, it's normal or high in hungry bone, but it's low in hypoparathyroidism. So look at the phosphate to differentiate between these two causes. A 50-year-old woman, she was admitted for UTI and she has temperature of 40, blood pressure was low, 90/60. She's dehydrated, has again hyperpigmentation. hyponatremia, hyperkalemia, hypoglycemia. So she's in renal crisis. She's getting IV steroid, broad-spectrum antibiotics, and volume replacement. Which of the following is the most appropriate next step? Cortisol level, cosyntropin stimulation test, IV mineralocorticoid, oral corticosteroid, or renal ultrasound. Would you like to vote on this one? Okay. Actually, the answer is A, cortisol level. I'm thinking of that. I thought that you would think of either A or B, but IV mineralocorticoid. I don't recall that we have oral the fluorocortisone. So patients suspicious of adrenal crisis, we check cortisol level, and if it's really low, that's okay. The reason they don't want you to answer cortisol stimulation test because they don't want you to wait before giving treatment. You can just draw the cortisol and you can give hydrocortisone. The other way, you can give dexamethasone. In that case, you still can do the cortisol stimulation test later because dexamethasone will not interfere with cortisol level that we measure after ACTH injection. But if you use hydrocortisone, it will interfere with measurement. So if the patient already got hydrocortisone IV, you have to wait. You cannot do ACTH stimulation at this time. Okay, 20-year-old man referred for genetic counseling of MEN2A. He elects to undergo genetic testing and found to have mutation. So this is the classic for MEN2, red proto-oncogene. Which of the following, so he's positive, which of the following appropriate next step in management? Periodic calcitonin measurement, periodic screening with imaging study, periodic screening for latent FeO, prophylactic parathyroidectomy, prophylactic total thyroidectomy. Go ahead and vote on this one. So this is MEN2A, so okay, I think only 10% of you get this. So the answer is E. We have to do prophylactic total thyroidectomy, so this is very important. In MEN2A and 2B, medullary thyroid cancer is very aggressive, and it's autosomal dominant with high, though incomplete penetrance, but it has high penetrance. So the way if it's positive for red proto-oncogene, they need to have the thyroid gland removed. For parathyroid hyperplasia, we can just monitor calcium level. Pheochromocytoma, do we need to screen? We will need to do that if we decide to do surgery for the thyroid. The reason we have to screen for pheochromocytoma before thyroid surgery is if they have it and we put them into operating room on the table, they can have hypertensive crisis. So this patient will need total thyroidectomy, but we have to screen for FeO. And if the screening was positive for FeO, we need to do the pheochromocytoma surgery first and then do the thyroid surgery later. A 26-year-old woman has a neck mass. The thyroid gland is firm, multilobular. The TSH is high, and the T4 and T3 is low. So the patient, so she has hypothyroidism. She has positive antibodies to the thyroid. So the biopsy of the thyroid mass is most likely to show. So they want to know what is the most common cause of hypothyroidism. Fibrosis, granuloma, lymphocytic infiltration, neutrophilic infiltration, or C-cell hyperplasia. No vote on this one. I think I just go. So the most common cause, it's okay, this start. The most common cause is Hashimoto thyroiditis. So you will see lymphocytic infiltration. Okay, I think you got the granuloma and the fibrosis, I can't find the arrow. The fibrosis is found in renal stroma, which is rare. Granulomas and neutrophil, we will find this in subacute granulomatous thyroiditis, so-called Gerger-Wang, and the C-cell hyperplasia is part of the thyroid, medullary thyroid carcinoma. Okay. This patient, 57-year-old man with moon face, buffalo hump, truncal obesity, so Cushing syndrome. So when he came, the early morning plasma cortisol is 35. So what they did is they give 1 milligram overnight dexamethasone suppression test. The next morning, the plasma cortisol is 6. Usually less than 5 is considered normal, so it's borderline. So they repeat with the standard low dose. Oops. I just cannot find the arrow. So 0.5 milligram for 8 doses, so for 2 days. And they check the urine-free cortisol is 30. And then they do the standard high dose dexamethasone suppression test, which can suppress the cortisol down to 10. So this, what can be the cause? So what is the diagnosis of this patient? So abnormal low dose dexamethasone suppression test, but the high dose can suppress the cortisol. Exogenous cortisol administration, hypersecretion of ACTH by adrenal tumor, hypersecretion of ACTH by pituitary gland or by small cell cancer, or hypersecretion of cortisol by adrenal tumor. So the answer is Cushing disease, is pituitary gland, because high dose can suppress pituitary but cannot suppress adrenal. So let me go ahead. So when we say Cushing syndrome, we can start with overnight 1 milligram dexamethasone test, and we can, now the ACTH level is also helping. If the patient has low, if the patient has high, very high cortisol, like more than 15, and the ACTH level, is low, so it means that the problem is where if the ACTH is very low and high cortisol level, it will be in the adrenal glands, correct? So think of 3 things: pituitary, adrenal, or ectopic ACTH. In the group of ectopic and pituitary, they have high ACTH. Only adrenal, that the ACTH will be low. So if you see low ACTH and high cortisol, you don't have to do high dose suppression. You can just go ahead and do imaging of the adrenal glands. But if the ACTH is elevated, you need to differentiate between ectopic ACTH and pituitary disease. And in that case, you need to do high dose suppression. This patient, let me just go quickly. High calcium again, calcium of 14. And this patient also have coil lesion in the lung. Now, what type of lung cancer can cause high calcium? Squamous cell, okay. But they didn't ask for the diagnosis. They asked, now because the patient has, she's lethargic, so she's symptomatic hypercalcemia. They can cause hypoactive bowel cell constipation. Which of the following is the most appropriate treatment? So symptomatic hypercalcemia, will you give IV bisphosphonate, normal saline, thiazide diuretics? This one will make calcium even go higher if you want to kill this patient. Bronchoscopy or collection of the sputum. So the answer will be to give IV fluid, right? That's the way to treat, to bring down the calcium. And because when they have high calcium, they will have they can have polyuria, so they even have volume depletion. And so if you can restore the volume, they can excrete calcium better. And IV bisphosphonate would be a good choice to do too. But after normal saline. Squamous cell cancer secrete PTH-related peptide. Okay. 32-year-old woman, sudden onset of palpitation and fatigue, and she began to lose weight. Chest insomnia. We look at the pulse rate of 120, and her EKG showed atrial fibrillation. So atrial fibrillation in 32-year-old. What should we do? So because this is endocrine session, so you probably will choose TSH, right? Three most common cause of atrial fibrillation: myocardial ischemia, mitral valve disease, and hyperthyroidism. So always check TSH in patients with atrial fibrillation. Now, this one is good. 32-year-old nurse. I don't want to. Sometimes they might say doctor. Complain of sporadic episode of lightheadedness and dizziness. Low sugar 50. Insulin levels is high, but C-peptide is low, and she has positive insulin antibody. Which of the following is the most likely diagnosis? Elemental hypoglycemia, insulinoma, surreptitious insulin administration, or surreptitious oral sulfonylurea administration? Please vote on this one. So approach hypoglycemia. Oh. Okay, 2, 3, 4. So now hypoglycemia with high insulin level. There are some possibility of insulinoma. So the answer B, C, and D can be correct, right? What we need to look at is the C-peptide. If it is insulinoma, the C-peptide will be high because it's endogenous insulin hyperinsulinemia. Proinsulin is secreted and it's metabolized into insulin and C-peptide, so it's come together. So in insulinoma, you will see high C-peptide. But if the patient is she's giving herself insulin to make herself hypoglycemia, the pancreas will stop secreting. So this is exogenous insulin. So the C-peptide level will be very low, will be suppressed. So if the C-peptide is low, it's surreptitious insulin administration. The other thing, if the patient instead, she's smarter, she said, I'm not going to give myself insulin, I will just take sulfonylurea, make herself become hypoglycemia. What does sulfonylurea do? It stimulates pancreas, right, to secrete insulin. So in that case, you will have high on both insulin and C-peptides. So if this patient takes sulfonylurea, they will have low sugar with high insulin and high C-peptide. Look the same as insulinoma. The only thing that we can tell is that we have to do either serum or urine sulfonylurea screening, which I don't think we can do it here. We have to send the blood to America to do the test. Okay, this one I will pass, we know already. After thyroid surgery, patient have facial spasm, so the cause is hypocalcemia. Okay, 25-year-olds having sore throat after upper respiratory tract infection. She's still having fever, pain in her throat, especially on swallowing. She has temperature 38.1, and in her throat there was no erythema or exudate. The thyroid gland is asymmetrically enlarged, firm, and tender. Which of the following is the most likely diagnosis? Graves' disease, medullary carcinoma, non-toxic goiter, papillary cancer, or subacute thyroiditis? Please vote on this one. So after URI, having pain in the thyroid and fever. Okay, 96%. So for the other 4% that answer medullary carcinoma, it's usually the thyroid nodule and it's not painful. Okay. So subacute thyroiditis, as we say, painful thyroid, previous URI, biopsy showed giant cell, neutrophil. It's self-limiting. But if they will go into the process of, they can have a hyperthyroid, hormone is high, and then low, and then return to normal level. But some people, if the inflammation is severe enough, they can remain having permanent hypothyroidism and may need to get thyroxine treatment. Okay, I think I may not do this one. Same, remember my first question? Flushing, diarrhea, wheezing, abdominal pain, heart murmur. Which test would you choose? So, carcinoid syndrome. Don't forget 5-HIAA. This is the management of DKA. Okay, 81-year-old woman admitted for worsening depression and dementia, history of type 1 diabetes. She's taking several medication, insulin. She lives at home and she has become increasingly withdrawn and confused. She's obese, her neck is supple, normal thyroid, clear lung. She has 1+ edema. She has poor concentration. Which of the following is the most appropriate next step? To check calcium, to do MRI of the brain, CT brain, to check for the RPR, or to check the TSH. So the answer is, sorry, don't forget hypothyroidism, though it's uncommon cause of confusion, but in elderly with new confusion or suspect dementia, like Dr. Nijasi just presented earlier, we need to check thyroid hormones. Okay, now it's gonna be, hypocalcemia may be seen most likely in pulmonary TB, sarcoidosis, chronic bronchitis, emphysema, asthma. You want to vote? Okay, so if you live here in the endemic area, you may choose, but if you're gonna take USMLE, you choose sarcoidosis, okay? Okay. This I added is not in the answer TB because they just don't see it over there. 17-year-old white female, polyuria, polydipsia. Let's see, I'm sorry, I think I passed this one. So DKA again, they ask many questions of DKA. So remember IV fluid. And the ABG in DKA, you will see predominantly anion gap metabolic acidosis. And the treatment of DKA, the serum bicarbonate, usually it's given when the pH is below 7. Okay, when you treat DKA, what do you expect about potassium? Number one, do you think the calculated, so which one is false, is incorrect? Calculated loss of potassium is about 5 MEq per K, or average of 350 milliequivalent in adult. During the course of therapy for DKA, serum potassium will increase as glucose penetrates cells and renal function improves. Hypokalemia on the EKG, you will see inverted T, depressed ST segment, prolonged QT, and U wave. Hyperkalemia, high potassium, you will see high peak T wave, widening QRS, and flat P wave. So please choose one. Just vote on this one. Okay, so you need to get the EKG session training again. So these are correct. This is the typical EKG change in low potassium. You see U wave in low potassium, high potassium topic T, so these are correct. Now, let me see. So most of you still choose the right answer. When you treat DKA, as glucose penetrate the cell, it brings potassium. So potassium is getting lower. So they may come in with potassium of 6 or 7. Once you treat with IV fluid and insulin, the potassium is coming down, and at one point you might need to even give potassium to the patient. Oops, sorry. Let's just pass this thing. Okay. Again, another question. Hypercalcemia with chest X-ray. I don't have the picture of this one. So now they ask, in squamous cell lung cancer, what is the cause of high calcium? A, macrophages are activated by M. tuberculosis in lung cancer. Okay. B, vitamin D is activated by immune mechanism. C, bone infiltration with tumor cells and production of PTH-like hormones. Or D, patients suffer from familial hypocalciuric hypercalcemia. Or E, is it pseudo hyperparathyroidism? So the answer, you know that it's it can be from osteolytic metastasis, the bone metastasis. Also, the PTH-related peptide can cause this. In vitamin D is activated, or macrophages. This is, you will see it in sarcoidosis or TB or granulomatous disease. Okay, 29-year-old pregnant woman, weight loss, tachycardia, anxiety. She's had history of thyrotoxicosis. She has tachycardia, diffuse goiter. So what should we treat? Radioactive iodine, propranolol, PTU, surgery, or not treated? Please vote on this one. Good. Okay, so the answer is PTU. She's pregnant, we cannot give radioactive iodine. She's pregnant, propranolol can cause fetal growth retardation. She doesn't really need surgery at this time yet. We just need to give her the PTU or even methimazole. And other sign symptom in this patient should be atrial fibrillation, can be found in hyperthyroidism, right? Reflex, hyperreflexia, hyperdefecation, just like a frequent bowel movement. Hypothermia is not part of that. Just to point to you, nephrogenic DI is caused, is the unresponsiveness of kidney to the antidiuretics hormone. So the body has ADH, but the kidney does not respond to it. That is part of nephrogenic DI. If it's central DI, it's the lack of ADH. Nephrogenic DI can be found in chronic renal failure, interstitial disease, acute pyelonephritis. High calcium and low potassium can cause nephrogenic DI. Also lithium and demeclocycline. So that's why we can use demeclocycline to treat SIADH. Same, if you remember, factitious hypoglycemia, hyperinsulinemia, we need to check C-peptide to differentiate that. Lithium, for the lithium, this short question, is an agonist of thyroid function, release thyrotropin hormone from the hypothalamus, is interfere with intestinal absorption of iodine, or it block release of thyroid hormones. So the lithium block release of thyroid hormone from the thyroid gland. It also inhibit release of I-131. So in thyroid cancer, if we want to treat with radioactive iodine, we can also use lithium to help the radioactive iodine stay longer in the tumor cells. I'm sorry to pass quickly. I think I'll just get to that's another part that I like to just have you go briefly. Okay, just a few more questions. So this one, the basic question is that the patient is having hyperthyroidism. So you discuss about treatment radioactive iodine. So you want to tell the patient that what can be the effect of radioactive iodine: arthralgia, granulocytosis, and a rash, improvement of ophthalmopathy, leukemia, the need for replacement dose of thyroid hormone within 10 years, or the treatment failure requiring repeating dose. So the answer will be the need for replacement dose of thyroid hormones. The most common side effect of radioactive iodine treatment of hyperthyroidism is post-ablative hypothyroidism. Arthralgia, granulocytosis, and rash is due to anti-thyroid medication. Now, improvement of ophthalmopathy, actually, it can worsen grave ophthalmopathy. So if you see patients with grave disease, and if they have active, moderately or severe grave ophthalmopathy, don't give radioactive iodine because it will cause worsen. If they have moderate degree and you want to give radioactive iodine, you have to give steroid coverage for about 4 to 6 weeks, and this will prevent worsening of ophthalmopathy. Excuse me. Don't look at that. Okay, now I don't have the answer, but you just tell me. This is just summarized briefly. Tell me the answer. 42-year-old obese woman, hirsutism, amenorrhea, difficulty becoming pregnant. What do you think of? Loud, please. So do you think of polycystic ovarian syndrome, right? Okay, you nod your head, but next.
I could go out.
47-year-old man, fatigue, dizziness, significant hyponatremia and hyperkalemia. Tell the answer. We have been past several questions. So Addison disease, right? Fatigue, hyponatremia, hyperkalemia. Think of Addison. 55-year-old woman, episodic paroxysm, palpitation, headache, sweating, high blood pressure, VO. 48-year-old man, diabetes, hypertension, mandibular enlargement, large hands, acromegaly. 35-year-old woman, constipation, hair loss, dry skin, hypothyroid. 45-year-old woman, excessive buffalo hump, high blood pressure, high sugar, Cushing. 55-year-old man, abdominal pain, kidney stone, hypercalcemia, primary hyperparathyroidism. So this is like summarize of what we have been talking. Last. You have one. Okay, this is last question, but I need to ask because it's not before. Okay, so 92-year-old man, lethargy, serum sodium was low, so hyponatremia. Serum osmolarity is also 260, high urine osmolarity. So this is inappropriate, right? If you have low sodium, you should have a low urine osmo, and urine sodium is high, 80. So what is the most likely cause of this patient lethargy? Please vote the last question. hyperglycemia, hyperlipidemia, hyperproteinemia, SIADH or DI. Great. Okay, so this is SIADH. Euvolemia, hyponatremia. Urine osmo is higher than serum osmo. This is the clue of it. And inappropriately high urine sodium. So remember, I think they have several of SIADH. You probably might see this question on the test. Thank you for your patience and good luck on your exam.
I am. Oh, there it is. Okay. There, I know there's food waiting for you out there, and all medical students thrive on food. But do you have any questions before you leave? Like herds of buffalo shall you go. Thank you. Oh, no?
No?
There is food waiting for them.
Okay. Let me land for a few minutes.
Oh.
The hosts are not here.
Oh, the hosts are not here. Okay. Seriously, are there any questions that we can pass on? And some of our speakers will be able, they have planes to catch a little later, but they will be here for a little while. So please feel free to ask them any questions you have in between bites.
Can you ask them our group going to be here soon or not? Ask them to call the hotel. เพื่อนผมที่อยู่โรงแรมว่ามาหรือยังเพราะมันกินก่อนไม่ได้ So I delay เป็นไงวันนี้เหนื่อยไหมเห็นหน้าตาล่วงโรย But it's very good, very in-depth review, neuro, endocrine. หาไม่ได้อยู่ไปหาที่ไหนก็ไม่มีใครมานั่งทำรีวิวให้อยู่ขนาดนี้ in-depth อยู่มีบุญมากที่ได้มานั่งวันนี้เลย แล้วก็ไม่กล้าถามแหมตอนนี้ยังไม่เรียบร้อยคือทวงรอนิดหน่อยเพราะว่าสปอนเซอร์ผมพวกคลาสเมทผมที่เขาสปอนเซอร์เลี้ยงกำลังจะมาแล้วพวกอาจารย์ที่มาเลคเชอร์เขากำลังจะมาจากโรงแรมถ้าเรากินก่อนก็น่าเกลียดใช่ไหมอีกสัก5 นาที10 นาทีคุยกันก่อนใครอยากถามอะไรผมก็ถามมาสิครับเชิญถามอะคุยกันเองตอนนี้ต่อไปนี้กันเองคุยแบบคุยเรื่องอะไรก็ได้จะเข้าห้องน้ำก็ได้แต่เดี๋ยวเพิ่งไปกิน เอ้าถามมาสิครับเชิญเลยครับอย่าหนีนะกลับมากินข้าวนะไม่มีใครกล้าถามสิใช้ไมโครโฟน